is Robin Elliott. I'm the president of the Parkinson's Disease Foundation. Good afternoon. Good morning, everybody. Welcome to the fifth talk in our fifth expert briefing series, PD Medications, Managing the Side Effects. I want to begin by thanking the sponsors of this program. The entire webinar series for this year, which is designed to cover some of the most important topics in Parkinson's today, has been sponsored by the AbbVie company, AbbVie Inc., and Teva Neuroscience. We're very grateful to those two companies, and as all of you understand, and as companies understand, the content of this exchange, of course, is solely the responsibility of PDF and its expert collaborators, and not those of the sponsors, but we're very, very grateful to the sponsors' support. Please notice that the PowerPoint slide deck can be downloaded from the reminder email you should have received this morning, or from the PDF webpage highlighting this talk. That's at www.pdf.org, the domain for our foundation. If you're a health professional of any stripe, you can earn one free continuing education credit, often known as CEUs, through the American Society on Aging. Some of you have already done this, I'm sure. If you are registered and indicated that you have a wish to a CEU, you should receive an email by the end of the day with steps on how to collect it. You have 30 days, I should warn you, until May 7. That's May 7 to collect the free CEU. Please, if you want to know more about Parkinson's or anything else that we do at the Parkinson's Disease Foundation, visit our website at any time, www.pdf.org. And you can learn there not only about the PDF expert briefing series, but also about anything else, all our other programs and resource materials and so forth. It's now my great pleasure to introduce our guest speaker for the occasion, Dr. Hubert Fernandez, very distinguished leader in movement disorders in the United States. He's a professor of medicine at the Cleveland Clinic, the Lerner College of Medicine, and other institutions in Cleveland. He joined the faculty many years ago at Brown University, went from there to the University of Florida, has held those major academic positions, has participated in more than 50 clinical trials, and has published his findings in more than 300 articles and abstracts on Parkinson's disease. He also has 40 published book chapters. It's an amazing achievement for somebody in young mid-career, which he is. So you're really hearing from an authority here this afternoon. He's also interesting to many of you, I think, on this call. He's recently been elected co-chair of the legendary Parkinson Study Group, which is the leading consortium, as most of you know, of clinical research into movement disorder, into Parkinson's disease clinical trials. And there's been a long succession of leaders of that group since it was founded a dozen or more years ago, more than 20 years ago, by Dr. Sandy Farn and Ira Schulson, Dr. Farn being the scientific director of the Parkinson's Disease Foundation, we're proud to say. I'm also proud to tell you we have more than 1,400, I think it is a record, people signed up for this conversation this afternoon from something like 26 countries and from every state and other jurisdiction in the United States of America. So this is a record roster for a subject that is very important to all of us. Dr. Fernandez, thank you so much for leading us today. He will speak from slides, which you should have in front of you, for a half hour, 40 minutes, and then we'll have questions after that, which I will help moderate. Dr. Fernandez, thank you, and the floor is yours.
Thank you so much. Can you guys hear me okay? I suppose that's a yes?
We assume they can.
Okay, wonderful. Well, at least, so thank you so much for that wonderful introduction, and thank you for the Parkinson's Disease Foundation, not only for this invitation, but for their really genuine and productive collaboration with the Parkinson Study Group. It is so much appreciated, and this is the least I can do is share whatever experience I have in managing Parkinson's disease, and especially with these side effects of the medications. You know, we are very fortunate as much as, you know, people, you know, our loved ones are suffering from Parkinson's disease. This day and age is in some ways good to have Parkinson's and mainly for the reason that we have lots of options. But when we have lots of options, or more options than other disorders, and some of them are equally good options, and it just boils down to which one is more likely or less likely to have side effects to a Parkinson patient, that tells us which direction we're dealing with. And although obviously your clinicians should know a lot of this, it is always nice to be an informed consumer. An informed customer, educated customer, is always in better footing than someone who relies completely on their clinician. Parkinson's is a lifelong disease. You're going to have it. If you're lucky and you have a good doctor and you respond well to medications, you can live a long, productive life, even with Parkinson's disease. But, you know, the wild card here is that you have to be invested in your own care just as much as your doctor should be. So I'm going to concentrate on Parkinson medications that are available now and the current side effects. And I apologize for a lot of our international listeners, where I concentrated on U.S. drugs, because that's the one I know, but some of them may be similar. And if I skipped on something, you can always ask me towards the end of the presentation. If I know it, I'll answer. The worst I can tell you is I don't know, and I have no problem with that as well. So here at these are just my disclosures. I am a clinical trialist, meaning I test drugs and devices by trade and by profession. So I have a lot of disclosures that I get support from these companies for testing their medication, but I don't get any direct salary from them, and I certainly have no owner pharmaceutical interests or stocks or anything from any of these industry partners, and also not-for-profit organizations. Okay, so first let's look at current treatment options for early Parkinson's disease. So when you're diagnosed with Parkinson's, what are our treatment options? The good news is that there's quite a few. There's more than one, which is always nice. The not-so-good news that we have is, if you look at this slide, it's busy, but my point here is that all of our current drugs work on doing one thing. Almost all of them work on a certain net effect, is that we realize that Parkinson's disease is in large part, but not in all parts, in large part because of a deficiency of production of one chemical or substance called dopamine. And dopamine is like the oil that we use in the car so that it runs smoothly. So without the dopamine, we don't run smoothly. So we're a little stiff, we're a little bit slow, we shake a little bit, and that's what the oil or the dopamine is doing. And all of the drugs we have right now, commercially available, work on increasing the amount of dopamine or improving the use of dopamine or delaying its breakdown so that more of it stays in the brain. So that's basically what this slide is showing, that it all works on augmenting dopamine to make up for the lack of production of dopamine in the brain. Now, the shortfall of that is that, yes, it is important. It's the greatest discovery that we've had, maybe not only in the history of movement disorders, but in the history of neurology and maybe in medicine, other than the discovery of penicillin, maybe. But we also know that dopamine is not the answer to all problems in Parkinson's. And because if it was, then by giving you dopamine, replenishing it, then you would be cured, right? But we feel better, but we're certainly far from cured, and we recognize that. And so we realized that there are other chemicals that might be involved, and we're now, thankfully, in the era of testing non-dopaminergic medications that work on a different chemical or a neurotransmitter, so that hopefully this will give us some benefits later on. So when you're diagnosed with Parkinson's disease, what are the usual treatment options we have? Certainly the best and most efficacious medication we have is carbidopa-levodopa, or Sinemet is the brand name. And then there are other less efficacious but still good alternatives for those who are not so severely affected, or for those for one reason or another may want to save the levodopa for later on. And that's the dopamine agonist, and then the MAO inhibitors, Amantadine, and Artane. So Artane is one of the first few drugs we've had, even before levodopa was available. And we don't use this very often anymore, so that's what I want to just cross that out very quickly. Artane or trihexyphenidyl, we don't use this a whole lot for a few reasons. One is that it's really just good for tremors. And thankfully, tremor, although it's probably the most visible part of a Parkinson presentation, it really causes more of a social embarrassment unless you're a lawyer or a dentist or a poker player or something like that. The tremor doesn't interfere with your day-to-day activities. It's more of a social embarrassment. So Artane doesn't really improve the stiffness or the slowness that we see in Parkinson's, but more of just a tremor, which is less likely to, as I said, involve the functional activities. On the other hand, side effect-wise, it has what we call anticholinergic properties, and therefore it can cause confusion, mental dullness, dry mouth, blurred vision, urinary hesitancy, etc. So because it causes more side effects, especially in the elderly, and it's only good for tremor, with the advent of better medications, we really don't use this drug too often. The more senior doctors who grew up with Artane, some of them still like it. I consider myself more of a modern clinician, and therefore I'm not so dependent on it. But every now and again, when you have a really medication-resistant tremor in a younger patient, younger meaning 50, 60 years old or younger, and really have bothersome tremor, sometimes I might try trihexyphenidyl or Artane. But other than that situation, for most patients newly diagnosed with Parkinson's disease, if they need a quick fix or their motor disability is more significant, I go for levodopa or a dopamine agonist, and if it's a little bit milder, I can go with Amantadine or rasagiline or an MAO inhibitor, but I almost always not use Artane anymore. So a few things about these options. So as I said, levodopa is the most efficacious drug, and the reason why this is most efficacious is because it when it gets to the brain, crosses the blood-brain barrier and gets to the brain, it gets converted to dopamine. And dopamine is the substance that's not being produced in enough quantities, so it's simply replacing the dopamine. That's why it works. Now, this carbidopa that goes along with it really is only an anti-nausea medication. So because levodopa, when it's not absorbed in the brain, it stays outside the brain, can be toxic and can be nauseating. So carbidopa prevents that from happening. And that's why this Sinemet, when I use the arrow, Robin, can you see that I'm using the arrow or not really?
No, we cannot.
Okay, that's fine. So the carbidopa, and to make it easy and convenient for us, the manufacturers have just combined it, built in. So for every levodopa that you have, there is carbidopa in that same tablet. And that's why there are two numbers. You have your medication 25/100. That means there's 25 milligrams of carbidopa and 100 milligrams of levodopa. The brand name is Sinemet, and it really is it's a clever way, why Sinemet? It's a clever way of naming drugs. I almost always don't understand how drugs are named, but in this case, it actually makes sense, because sin in Latin means without or no more, and met in Greek means vomiting or to vomit. So no more vomiting, that's why it's called Sinemet. So it has immediate release, so that this is the most commonly used drug, Sinemet IR or carbidopa levodopa IR, or simply if it's not mentioned, it's presumed that it's immediate release. So it's quickly absorbed, it works in about half an hour, and it lasts longer earlier on and shorter as the disease progresses. Sinemet CR has a special coating so that it gets dissolved by the stomach juices a little bit slower. So its absorption is slower, but because it's absorbed slower, it also is utilized longer and has a longer duration of action. In theory, that's how it is, but in practice, it's not as reliable as the immediate release. So we tend to not use it a whole lot. But for in certain situations, like let's say at night, because there's a long gap between the last dose at night and the first dose in the morning, we can use CR. Parcopa is the opposite of CR. It melts in your mouth, and therefore you don't need to drink water with it or juice. But it still gets absorbed in the stomach, and therefore its duration of action and also onset of action is not any quicker than immediate release. Now, with advancement, there is this Stalevo or entacapone. Stalevo is mainly Sinemet, which is carbidopa and levodopa, with entacapone. This is a triple compound combination. Entacapone can simply be thought of as a Sinemet extender. So if the medication isn't lasting long enough, by adding entacapone to the carbidopa-levodopa combination, it lasts longer. So that's why it's called Stalevo. Now, dopamine agonists, there are 3 that's commercially available, at least in America. There's a few more outside America. So ropinirole or Requip is one, pramipexole is another, or Mirapex. These now have generics. So the generics are 3 times a day, and then the brand name is once a day or extended release. And then there's the new kid on the block, rotigotine or Nupro patch. In other countries, you have Peribidil, that's also a dopamine agonist. And MAO inhibitors, you have Rasagiline or Azilect and Selegiline. And then you have Amantadine. Let me just move on quickly here, otherwise I will never finish. So levodopa is the best drug we have. It works quickly. It certainly has prolonged the lifespan of patients since its inception. And it improves a lot of the motor symptoms of Parkinson's. Not everything, but a lot. And it works very quickly. Once you reach the right dose, it works pretty much that week or that day even. However, 80% of people taking levodopa develop motor complications after about several years of taking it. Specifically, the one that's a biggest visual stigma is the Dyskinesias, or the Michael J. Fox-like movements, dance-like movements that people see. And because of that, there is a group of people who are so, what do you call this, afraid of levodopa, and they avoid it at all costs, which, hopefully if there's something that you learn, I'll give you some proof that please don't be too afraid of this. 1, you may never have it, and 2, when it gets if you get dyskinesias, not everyone has this disabling dyskinesias. In the meantime, by avoiding it, you could be deprived of a good quality of life by depriving yourself of the best medication we have for Parkinson's. So if you look at this, levodopa, if you compare every drug that compares themselves to levodopa, is like hitting themselves on a brick wall. You could see here when pramipexole or Mirapex compared themselves to levodopa, levodopa was superior, the clear winner in improving motor side effects. When Requip or Ropinirole compared themselves to levodopa, levodopa won again. The problem is the dyskinesias. But dyskinesia is really a more scarier thought than it actually is. So this is one of the long-term studies that I'd like to highlight, the Sydney study. They followed patients at varying degrees of starting point, and for 15 years. And you can see here, over 10, 15 years, indeed, lots of patients develop dyskinesias. However, if you look at the next graph, dyskinesias requiring medication adjustment, it's less. And then if you look at the third graph at your far right, dyskinesias that are resistant to medications, it's really not as much. So yes, it can be common as time goes on, but it usually can respond to medications. And there are still obviously a few that are resistant, but they're the lesser common variety than those that respond to medications. So here is another one. Just the scariest thing about dyskinesia is the perception of it. This is one study that I like to quote a lot. So this study is very simple but very elegant and it has a good take-home message. They group people into three. One is those that are untreated yet, they have Parkinson's, they are not yet treated. The second group in the middle is the one that is treated, but they don't have dyskinesias. And the third are those that are treated and they're having dyskinesias. So if you look at this, group one, those that are not treated yet, they are the yellow bar is the one that has the most concern for dyskinesia. So look at the level of concern for group one, those that are not treated. Oh, they're very scared of having dyskinesias. Group two, they're treated already, but they don't have dyskinesias yet. See, they're still scared, but not as much as those who haven't started medication yet. And then group three are those that are actually suffering from dyskinesias. Look at that. That dyskinesias is the least of their problems. They are more concerned about other things in life. So the concern for dyskinesia is really more of a scare rather than it's a perception issue rather than an actual issue. Of course, I'm not saying that there are still patients who suffer from dyskinesias, but the majority of them, it's more of being scared that they might get it rather than actually getting it. And another one is if they were asked if they would prefer dyskinesias over Parkinson's, overwhelmingly they would prefer being dyskinetic than being Parkinsonian. So here, from those who are not having dyskinesias, they don't know. It's a split decision. Some prefer to be more Parkinsonian than dyskinetic. In group three, those that are having dyskinesias, they much prefer having dyskinesias than Parkinson's if they had to choose one or the other. So please don't be scared too much. So dopamine agonists, what are these? So these are the new Patch, the Mirapex, the Requip. Now it has a generic equivalent. So that's the 3 times a day, but it also has a brand name if you want just once a day. They're equally efficacious, equal side effects, equally efficacious. So the only thing you're paying for the generic, for the brand name of this, is the convenience. And sometimes that's worth paying for, and sometimes it's not. So that's up for you to decide. But the biggest advantage here is that the reason why we use it is that we tend to delay the dyskinesia appearance if we use it first. So if you look at this, the green ones are the ones on levodopa, and the blue ones are the ones on the dopamine agonist. Every time it's compared, although levodopa is superior, as I showed you in the earlier graph, they are more likely to develop dyskinesias compared to those who are on dopamine agonist alone. So, however, dopamine agonists have their own problems. It takes a little bit longer for them to get to the right medication level, longer titration period, and in the elderly, so this is 70 years old and over, they have more side effects. Causes more nausea, hallucinations, more lightheadedness, more sleepiness. And then it has these two, not so common, but very, it can be disturbing side effects. The one is sleep attacks. That this is sleeping without warning. This is different from taking a pill and, I'm feeling tired, I want to go to bed. This one is you don't feel tired, you're driving or you're eating or you're talking to someone and then all of a sudden you fall asleep. That's what we call a sleep attack. That's very rare, but it happens in patients with dopamine agonists. So if this happens to you, especially if you drive a lot, you have to let your doctor know. It can also cause some leg swelling and therefore weight gain. And then the one that's most talked about is that these dopamine agonists can cause impulsive and compulsive behaviors. Okay, so these are the too much, soliciting for too much sex, buying lots of things, gambling, and things like that. It happens rarely, but when it happens, it can be devastating. So you have to be on the, vigilant about it. So this is the sleep attack that I was talking about, where people are just fall asleep, a representation while they're doing something. This is different from sleepiness that occurs with the drug when the drug has side effects. And patients on dopamine agonists can cause weight gain and leg swelling as well. And if you look at this, if you compare a dopamine agonist to levodopa, you can see that the dopamine agonist in blue has always more side effects. This is especially in the elderly compared to levodopa. So the same way with the pramipexole, more side effects, more somnolence, hallucination, edema. Although the hallucination is less than 10%, it's still more common in dopamine agonist rather than the levodopa. So the patch is one. There's a good thing about the patch is that it's only once a day, and then the other thing is that you don't take it, swallow the pill, so there is less nausea from it. On the other hand, because it's a patch, you could have this red-like rash. You could see in this gentleman, where the patch was. If it's just like that, there is enough body surface, you could just move it, and by the time you move to different areas of the skin, and then by the time you get to the same part, it's already resolved, so that's fine. But if it's more than that, then you might be allergic to that, to the silicone or to whatever ingredient in the patch is, and it may not be the best drug for you. Okay, so there are lots of impulsive, compulsive behavior. Gambling, hypersexuality, compulsive shopping, binge eating, excessive spending, they're a bit, self-explanatory. You know what it is. Punding is a bit more difficult to explain. So punding is an obsession to doing something over and over and over and over, nonstop. And so in itself, it's usually not dangerous, but when people pund, they tend to skip meals or not even skip their medication, and they become irritable if their spouses stop them from doing it. So it can cause a lot of family dynamic problems as well. So there was one study that looked at dopamine agonists. I mean, there are lots of studies, but the largest study that looked at dopamine agonists in over 3,000 people. It did show that people on dopamine agonists were at higher risk of developing impulse control behavior disorders. It's not very common. As I said, I don't want to scare everyone. It's a good drug. You just have to be on the lookout for this so you can nip it in the bud in case things develop. So people on dopamine agonists were 2 to 3 times more likely to develop impulse control behavior disorders as compared to those who are not on dopamine agonists. And if this is our study when I was still at the University of Florida, as you can see, the incidence for these compulsive behavior is less than 10%, sometimes less than 5%, and sometimes 1% or so. But it's not much, so it shouldn't prevent you from taking the medication if your doctor thinks that this is the best thing for you. But you need to be an informed consumer, so if there are signs to this, then you can tell your doctor immediately. One thing that I would advise, Parkinson patients are the most charming patients. Charming. And they can talk their way into, well, I didn't really gamble, or, well, I'm retired, I've earned this, I deserve this. Yes, that's true, but if it's different from your baseline, then it's probably a medication side effect. So this is where I rely on the spouse a lot. And I talk to the spouse and make sure that when I ask these questions, I'm looking at both their faces and not just on on the patient's face. Because the patient will always deny and say something, but the spouse is a bit more grounded. Sometimes the spouse can be overprotective. So there are times in the interview where I have to rely on my patient because they're the patient. They're the one who's suffering from it. But for compulsive behavior, I rely a lot on the caregiver or the spouse because they know how their husband or their wife was previously, and they know how it is now, how they are now. And so I put a lot of weight into that. So these are just some examples of punding. So we have collectors. Some of them are very neat, and then they collect all these things, cans, jewelry, whatever. And others are messy, oftentimes actually messy, and they assemble and disassemble things all day long. And so that's punding. Now, there's just this emerging theme that I'd like you to what is the one theme that can occur very commonly in the computer age is the computer. So there could be internet gambling, and therefore, because it's not in the casino, they say, I'm not gambling, but they are. They could be gambling just in the internet. Pornography in the internet or whatever is another way. And for punding, computer games, playing the games all day long, all day, or sometimes assembling and disassembling computers is another form of punding. Okay. So anticholinergic drugs, as I said, I don't use very much Artane and Cogentin because they're really just good for tremor and sometimes for drooling too. But they cause a lot of these anticholinergic side effects, as I mentioned, the confusion, dry mouth, et cetera, et cetera. So I don't use that a whole lot. And then you have the MAO inhibitors. How do I do this? So how do I explain what the MAO inhibitors, how do they work? Well, normally, so there is just the right amount of oil so that the car would drive smoothly. So there is just the right amount of dopamine so that we think clearly and we move smoothly. If we don't have enough dopamine, we develop Parkinson's disease. And guess what we develop if we have too much dopamine? We develop the opposite of Parkinson's is schizophrenia. When you act and you think crazily and there is hallucination and delusions and stuff like that. That is because of too much dopamine in the brain. So our brain is wired so that there is just the right amount of dopamine. And how do we do this? Well, once we use the dopamine, there are what we call these garbage cleaners. There are enzymes that break the dopamine into smaller pieces so that they can be cleared away and off the brain. And one of the enzymes is the MAO enzyme, okay? monoamine oxidase enzymes. So what they do is they break down the dopamine after its use so that they can be cleared and taken off the brain. Because if we have too much dopamine, the patient becomes psychotic, or the person becomes psychotic. Well, in Parkinson's, there isn't enough of the dopamine, and then this MAO-B enzymes are still there breaking it down. So we want the dopamine to live longer, to stay there longer, because it's not being produced in sufficient quantities. So what this drug does is that it blocks the enzyme that breaks down dopamine into small pieces so that more of it stays alive in the brain. So that's what it's doing. So it's kind of indirect. It doesn't produce more dopamine, but it keeps them longer so that there's more of them there. And so it's not as strong as you would expect compared to Sinemet or Levodopa, but it's a good drug. So let me just, early monotherapy, it's good. It's, rasagiline, Azelac is the most commonly used MAO-B inhibitor. It's one dose. It's well tolerated once a day. You don't have to worry about sleep attacks, compulsive behavior, and things like that. However, it's deemed as not as powerful or not as efficacious as Levodopa, and maybe not as efficacious as the dopamine agonist. But there has been no head-to-head trials to really prove that. It used to be that there was a lot of things that you can't eat with Azelac or rasagiline. Now you can eat anything you want in moderation. There is no, interaction. Now, as the disease progresses, in a lot of patients, they develop what we call motor fluctuations, when the medication doesn't last long enough and they have wearing off, and when they get these dance-like movements called Dyskinesia. This is just the, early in the disease, in the first one, despite fluctuations in the drug levels of Parkinson patients, the green window is very wide, and so patients don't feel the ups and downs. But as the disease progresses, this green window narrows, and therefore it may not last as long enough as they want it to be, and then the one above the green band is the Dyskinesias that we have. So how do we manage Dyskinesias? Lots of choices. When generally when Dyskinesias occur, that means there is a little too much Levodopa. So we can lower the dose of Levodopa, but if you lower that, you'll have wearing off. And so you can make it more frequent. You can add a dopamine agonist, or you can add an MAO-B inhibitor while lowering Levodopa dose. You could add Amantadine. Or if the Dyskinesias are really bad, then you can, or significant, then you can do deep brain stimulation surgery. Amantadine is our best drug for Dyskinesias. You could see that the dyskinesia time and the degree of Dyskinesias got better with Amantadine compared to placebo. So that's one drug that can improve Dyskinesias and not cause much side effects. However, they still have their own side effects. It can cause leg swelling, just like the dopamine agonist, and it has this very strange rash called livido reticularis. It's like a lace-like rash. It looks ugly, but it's generally harmless. So you can't wear a miniskirt if you have this, but you can still walk perfectly fine. And then sometimes it can cause anticholinergic side effects, but not as much as the artane that I was mentioning, and hallucinations as well, like any other medication. So this is an example. Of course, this is extreme, but I wanted to give a graphic that you'll remember of this lace-like rash. This patient absolutely feels fine. Feeling-wise, it's not itchy, it doesn't hurt, nothing. But you could see that the legs are a little bit swollen, maybe not a whole lot. But there's that lace-like rash. So if you don't mind wearing pants or long skirt, you're fine. But if it becomes really bad, then you could tell your doctor. if we get rid of the medication, it usually will go away over time. Okay, so the COMT inhibitors, I mentioned this a while ago in the Stalevo. Remember the triple compound with the carbidopa, levodopa, and the entacapone? So when it's built in the Sinemet, it's called Stalevo, but it can also be on its own. When it's on its own, it's just simply called entacapone or Comtan. There is an older brother of entacapone or Comtan called Pasmar or Talcapone. It's still available in some countries, but not in all countries. And the reason why it's not available in most countries is because it doesn't mean it will, it can cause liver toxicity. And so it's not easily available. And if you have to use it, you have to do liver function testing to make sure that things are fine. So this Comtan is a Sinemet extender. So it extends the life of the Sinemet. And so we use it for wearing off patients. So here there are 4 studies. It improves off time by 1 hour at the minimum. So 1 hour, like, wow, what's 1 hour? Well, for some people, 1 hour is a big difference. That means they can take a shower, or they can now do the grocery, or have time to play bridge and then rest. In some cases, 1 hour is not enough. So rasagiline, the MAO inhibitor, the one that breaks down or blocks the MAO, the enzyme that breaks down levodopa, it can also extend the life of the Sinemet, and it also improves it by 1 hour. And if you compare rasagiline versus entacapone, they're absolutely the same, about 1 hour each. So one is not more superior than the other. Just a plug about apomorphine. It's a dopamine agonist, but so the good news about that is that it works quickly. In about 5 minutes to 7 minutes, you feel its effect. The bad news is that it wears off in 1 hour. So if you have to use it as your mainstay drug, then you have to be injecting yourselves every hour. So it's not used for that. It's only used as a rescue medication for off periods. So I use this a lot in unpredictable offs, or when the off is painful, or when the off is really bad, and so it makes them comfortable while waiting for the regular oral medications to take effect. So this is the injection, and it's like an insulin injection. It's really almost painless. It's easy to use. It's just intimidating that it's an injection, but otherwise it should be okay, fairly straightforward to use. So here is the list of all medications: the dopamine agonists, selegiline, MAO inhibitors, COMT inhibitors, the entacapone. And the bottom line that I wanted to share with you is that almost all of them really work for an hour to an hour and a half. So they're not like they help, but when the wearing off is really more significant than it should be, it's not the most useful medication. So what about when the wearing off is really bad? And the Parkinson's is a bit more advanced than it should be. So here is a good perspective that, if you try the oral agents, it gives you 1 to 1.5 hours. If you try the injections, well, it's kind of your own, you choose when you want to use it, but it could give you potentially more the more you use it, 2 to 3 hours. But then there's this, you have DBS, which we offer, and then there's this new kid on the block. It's been available in Europe for a decade or so. It's finally coming to America. The FDA is reviewing it as we speak, and hopefully it'll be available to us. This is levodopa that's in liquid gel form. So it's delivered through the stomach and ends in the small intestine. So all you have to do is put the cartridge on, and it just gets delivered through a tube directly to the stomach, and you don't have to worry about it. You set it and forget it, right? So as the disease progresses, a multidisciplinary team is certainly very necessary. This just reminds me of my trip in Tanzania. I gave a lecture there, and it's not a very rich country, but this is their village where the chief is in the middle and everyone has an equal voice to solve the problem. So in a way, in Parkinson's disease, the patient has to be in the center, and the best success we have is if the patient is a patient-centered approach. The patient is in the center, and the resources needed by the patient, whether it be psychiatrists, psychologists, neurologists, physical therapists, occupational therapists, speech therapists, are really revolving around the patient, as opposed to the patient going to each of their clinics and stuff and making it very difficult. Just as a reminder, as much as we're talking about all the tremors and the stiffness and the slowness, that's really just the tip of the iceberg. What lurks underneath are really this non-motor signs and symptoms that patients may not even know is part of Parkinson's, but you need to know them. You need to recognize them, because if you don't tell your doctor won't know it because they can't see it. They can see the tremor, they can see dyskinesias, but they can't see cognitive impairment or pain or constipation unless you mention it to them. The most difficult one is the neuropsychiatric symptoms, but fortunately they're also the most treatable ones. We can treat depression, we can treat psychosis, we can treat anxiety, and to a certain extent we can improve cognitive impairment. So you have to mention to your doctor if you have any of this. And so I'd just like to end. I know I went 10 minutes over. I'm so sorry for this, but I'd like to really end with a message of hope. You could see here, there are a drug in order to be approved for general consumption has to pass the phase 3 trial, and then the bullseye is that yellow shade in the center. And you can see phase 1 is only in normal college students who need money for their summer break, and then phase 2 is in a small number of Parkinson patients. That's the green one. Phase 3 is in a larger number of Parkinson patients. That's the light green one, and if it's successful, then it gets marketed and it gets to the yellow circle. And you can see here there are lots of medications that are trying in clinical trials to reach that yellow bullseye. So hopefully, when you invite me again to give you a talk, I could give you better reports on successful clinical trials that can improve a lot of patients' lives. So,
wonderful. Thank you so much, Dr. Fernandez. We'll definitely invite you back. How about next week? What are you doing on Tuesday? That was really terrific. As a measure of really good talks is that we have even more questions than usual, and we have dozens.
Okay.
Clearly, we can't get those done in this period. So I'm going to say now, if I may, with advance permission we got from Dr. Fernandez, we will continue for at least 10 minutes over the hour, maybe even 15, but not longer than that. And for those of you who can stay, please do stay, and we'll cover as many questions as we can. And then if you have not had your question answered, which I'm afraid is probably more likely than not, then please call our hotline. You know how to do that, I think. You've been instructed on this. It's in the... the telephone number is 1-800-457-6676. That's 1-800-457-6676 if you don't have your question answered. So let's just get to the first of our many questions that we've been going through while Dr. Fernandez was speaking. A person from California has a question that one of the few that he didn't answer, which is, Dr. Fernandez, is there any difference in side effects between the generic and the brand name? So when a brand name drug goes generic, choose your example if you have one, do side effects tend to go along with it? Is that profile the same whether a drug is brand name or generic, or is it more or less likely when the thing goes off patent?
Yes. It's a great question. Thank you for asking that. So first of all, it's not part of the question, but I'll still say it. Efficacy-wise, there is no difference whatsoever. In fact, that is the one condition that the FDA needs in order for it to go to generic. You have to be as close, if not identical, to the effect of the drug that you're changing to generic. So if you're less efficacious, then your drug is different from that drug, and it cannot be approved for generic. So you can be assured that of course there will be some patients who will like one more than the other, but for the most part, it should be equally efficacious. Side effect-wise, the generic dopamine agonists really are longer-acting. And because they're longer-acting, they may, not necessarily, but they may have less nausea along with it because it's kind of less abrupt in their absorption. Now, that difference might be felt more from someone who's starting a dopamine agonist. When you are already on a dopamine agonist, you're used to the medication. And so, for the most part, when I switch my patient to the generic drug, they wouldn't feel much of a difference because they're used to it already, or vice versa. Okay?
Thank you. Here's a question from New Mexico. The caller would like to know, who's experiencing apparently excessive sleepiness. She or he doesn't say that it's with one of the agonists or anything else, but they're simply saying they have excessive sleepiness. Is this a side effect of some drugs, or is it a function or an adjunct function of Parkinson's itself?
Well, first of all, I'd like to assure that caller from New Mexico that excessive or significant daytime sleepiness is very common in Parkinson's disease. Almost all Parkinson's patients have some daytime sleepiness that they'd like eradicated. And the source of that is multifactorial, meaning there are several reasons. All the Parkinson medications, maybe except rasagiline, but all the medications can cause sleepiness, just some a little bit more than others. So the dopamine agonist, probably more than all the other drugs, but all the other drugs can also cause sleepiness. So that's one source. The second source that we thought was largely the reason, which we now know that it isn't, but it's still partly the reason, is because they don't have a good sleep at night. So if you don't have a good sleep at night, then you have to make it up in the morning, and therefore you're napping and you're sleeping. So that's another reason. And the third, there are behavioral complications that can go along with Parkinson's disease. Depression or apathy, which can be different from depression. Apathy is more like just caring less about things or about your surroundings. And therefore, when you're less motivated, you also are kind of sleepy and tend to nap. And so these are just some of the things that can contribute to sleepiness in Parkinson's. So if the patient is on a dopamine agonist, then you have to weigh whether whatever the benefit of that pramipexole or ropinirole is giving is worth the sleepiness that it's doing. If it is worth it, then you might want to consider adding an alerting medication. An example of that would be modafinil. It's a drug that's approved for narcolepsy, but we use it also for excessive daytime sleepiness. The insurance might give people a hard time, but if you can afford it or we can get away with it, then certainly it's one of the alternatives that we can do. Now, you might realize that, well, it's not worth it. I don't really get a whole lot from it anyways. Then you could switch it to something that might cause less sleepiness, like levodopa. So there are a few choices, but then, yes, it can be a source of sleepiness, but there are other sources of sleepiness as well.
Good, thank you. There's an underlying theme that goes through so many of your comments and now your answers to these questions, and that is the cost-benefit analysis, that no drug is perfect, that many of them have some side effects, and so you're constantly juggling, as the person with Parkinson's or as his or her doctor, you're juggling the pluses and the minuses, and that's what's so endlessly fascinating and sometimes frustrating about this process, because and I think you're making that point in different ways throughout your presentation. I think that is a general theme. Would that be fair to say of your whole talk?
Absolutely. It's, we don't, doctors, your clinician, he or she, they don't have a crystal ball. If they do, they're faking it. Sure.
Good way of putting it. We have a call from the United Kingdom, this part of this person's question was answered, but there's a twist at the end which I wanted to ask Dr. Fernandez. The person is asking, are the side effects of levodopa minimized if the dosage is kept low? And Dr. Fernandez actually answered that when he said that one of the things you do to reduce these side effects is to reduce the dosage. So that part was answered. But the person goes on to ask, does the drug remain effective enough during that period, so that if you were to reduce levodopa, as one of the suggestions you made for reducing the side effects of levodopa, then at what level is it still helpful, or are you, in order to get rid of the side effects, are you reducing it below the useful efficacy level?
Yeah, that is certainly very possible. And if you reduce it too low, obviously, you run the risk of making it less effective. It's all about therapeutic levels and therapeutic windows. If your window is large, we have the luxury of reducing it, and you wouldn't feel much difference. But if your window is narrower, then you might feel the effect of lowering the medication. So, so yes, it can happen. So if the patient, for example, has peak dose dyskinesias, and for some reason, usually they're actually not bothered by it. The spouses and the family surrounding the patients are the ones more bothered by the dyskinesias. But for some reason, if the patient is bothered by it, or he or she cares so much about his family that he don't want them worried and request, you've got to get rid of this dyskinesia. So one of the things we can do is we can lower the levodopa. But when we lower the levodopa, yes, we can cause more wearing off. Now the dose is low and it doesn't last until the next dose. So that's what we call wearing off. So how do we cut our cake and eat it too? What we can do is we lower the dose of the levodopa, but we narrow the dosing frequency. So if you were taking the pill 3 times a day, we cut it in half, but we make it 4 times a day, or we make it 5 times a day. So if our calculation is correct and we're lucky, we might get away with it. But you have to be patient. As I said, your doctor doesn't have a crystal ball, but he or she should have enough information so that the guesses are a bit more educated, and more likely it'll be to your advantage rather than to your disadvantage. So it's all about rolling the dice and betting on things that have a higher yield than those that are lower yield. But no doctor will always have, a straight flush. It can't be. But if you play your cards wisely, then it's to your advantage.
Very good. Thank you very much. There's a question also from the UK. I promise we're not favoring people with funny accents, but this one does come from the same place. And it's about DBS, which is why I wanted to get it in there, because we haven't talked about surgical methods yet. And the question is interesting. I think probably a pretty direct answer for it in what you've already said. If you have DBS, then are you likely to suffer less risk of side effects from the typical Parkinson medication than if you do not have DBS? And my understanding is that with DBS you have a lower dosage than of the other drugs, Dr. Fernandez. So is the answer to that straight yes? If you have DBS, then you'll have less use of drugs and therefore less side effects, or is it more complicated and interesting than that?
Well, it's mostly yes. Now, there are different targets now for DBS and Parkinson patients. The 2 leading targets, the most common one is the STN, or subthalamic nucleus. And when patients get DBS targeted on their STN, for some reason, we are able to decrease total Parkinson medications by an average of 50%, sometimes more, and 75 to sometimes 100%, and sometimes less, just 25% or 30%. The decrease in dopamine medications is really a consequence for the most part, not a goal, but a consequence. So obviously, if you have less of the medications, then correct, you have less of these side effects. Now, there is this other target called the GPI, or globus pallidus internus, where it's very good for patients with dyskinesias. And the advantage of this is that, one, it's good for patients with dyskinesia. It has an intrinsic antidyskinetic effect. And the second is that most authorities feel that it's slightly more forgiving with regards to DBS side effects per se. There is less cognitive decline. There is less behavioral, dyscontrol when you have GPI as opposed to DBS. But the disadvantage is that your Parkinson medications remain essentially unchanged. So if you're sleepy with a medication and you'd really like to have a best chance of getting rid of that medication, then the GPI target may not be ideal for you. So for the most part, that's why for the most part it's a yes, but there are some situations where we are unable to decrease the medication total. The DBS mainly kind of complements the medication, and you have a smoother ride, but you don't get rid of the medications, and that's mainly for the GPI, and therefore the side effects stay.
Very rich answer. Very, very good. Thank you very much for that. I learned a lot. We have a call from Turners Falls, Massachusetts. This person was interested in your comment about compulsive behaviors associated with dopamine agonists, and she wants to know, in general, do those behaviors stop when you stop using the agonist, or do they continue for a while, or what happens?
Yes. So England, then New England, huh?
Yeah, that's right.
So, yes, the answer to that is yes. Almost immediately, meaning within a week, and sometimes within a day or two, when you get rid of the offending dopamine agonist, that feeling of scratching lottery or gambling or soliciting for sex or whatever it is goes away almost immediately, meaning not that minute, but within days or within weeks. Having said that, when we withdraw a dopamine agonist, there is now this being recognized condition being increasingly recognized called DAWS, D-A-W-S, Dopamine Agonist Withdrawal Syndrome. So it's easier, what I'm telling the audience is that, yes, when you have impulse control behavior disorder, the obvious treatment is to get rid of the dopamine agonist, and yes, when we get rid of the dopamine agonist, it is almost an immediate effect that this impulses and compulsion almost always goes away. But it's easier said than done. When we abruptly withdraw the dopamine agonist, people feel not good, uneasy, maybe even agitated, more off periods. They just don't like that feeling. And they end up, well, I'd rather feel less crappy and a little bit, and they're back on it. So what we've been doing now is that we are very careful in backing off on the dopamine agonist. We cut it in half, so at least it doesn't worsen the picture, and maybe it helps a little bit, but there might still be tendencies every now and again. And then we wait and see how much we need to make up for that half that we cut. And then if the coast is clear, we cut it again in a quarter, and then see how much we need to make up for that cutting for another quarter. And if the impulse control behaviors go away completely or near completely, we don't need to get rid of it all the way. We just keep the dopamine agonist there at a low, very low level. And if it's still there, then we cut it completely. But it's a bit more gradual. That way we're a bit more successful in getting rid of the medication.
Very good. This next question is slightly related. You mentioned compulsive disorders were a possible side effect of agonists. Another one is sleep attacks. And this question from Pennsylvania has to do with sleep attacks. And if I can slightly reframe this person's question, I hope without ruining it. A question would be, if this person who is finding the agonist generally useful has sleep attacks, is there something you can do about the sleep attacks without simply stopping the agonist?
Yes. You cannot drive. You can hire a chauffeur. The second is you can lower the dopamine agonist dose and make it up to with another medication so that you get the same net effect as if it was you have a full dose, but you now only have half the dose and then half of another medication, maybe a low-dose levodopa or rasagiline or something like that. But there are cases where if you cut the dose a little bit, the sleep attack gets better. Now, there are cases that it doesn't matter what dose it is. As long as the medication is there, you have a sleep attack. Then for those cases, you have two choices. You either have to give up on the drug and get rid of it, or the second is you keep the drug but add an alerting medication. So now we have these medications that are not amphetamine-based, but they're alerting, like modafinil, which we now use quite a bit. The only tricky part about that is insurance coverage of that medication, because it is, as I mentioned earlier, it is approved for narcolepsy, not for sleep attacks or excessive daytime sleepiness in Parkinson's. Before this, when we had no choice and an off-label use, we would give amphetamine-based medications to keep them alert. Coffee is a medication. It's a substance that is rather enjoyable to take. Is, as you know, alerting, and as we have some preliminary reports that it also improves Parkinson's symptoms, but you need to drink a lot of it, 2 to 4 cups of like high level, strong.
And then you're going to get into the side effects of caffeine. So maybe that becomes something.
Those are generally your options.
Yeah, that's wonderful. I have one more question. I'm going to take this one because it talks about the combination of different things. Now, we're dealing today with side effects and not with interactions. And maybe the next talk should be about interactions, because that would be a talk all by itself. But I'm going to throw one thing in here that is of that kind. And it's a question from Toronto in Canada. The questioner would like to know that if she is taking an antidepressant, such as Effexor, along with Sinemet, levodopa, carbidopa, are there going to be side effects of that combination or interaction between those two? I'm sure it's a whole chapter by itself, Dr. Fernandez, but I'd be interested in whether there's any answer to this and a generic comment you'd like to make from that about when one is combining one of the Parkinson's drugs with something else that is dealing with a piece of the symptom in some way. Then are there side effects of that combination? I realize that's a very complicated question, but any reflections on that?
Yeah, sure. General reflection. The good news about Sinemet and about the stomach is that it's an incredibly intelligent organ. It knows what to do, and it knows where to go, where to put the drugs, and et cetera, et cetera. It's a joke, but the Sinemet largely doesn't interact too much with other medications. So Effexor, for example, is perfectly fine to take along with the Sinemet. In fact, I just encourage my patient to take all their other medications when they're taking Sinemet 4 times a day or 5 times a day, and they tend to forget things. I tell them to take all the other non-Parkinson medications along with one of the 4 doses of their Sinemet, so that their life is not ruled by taking medications. And at least they're just taking pills 4 times a day, and that's it. There's no more between those medications for other things, because they're very scared that they might not get the full effect of the levodopa. If there's anything that might interact with levodopa, one is protein. So levodopa broken down into our large amino acids. So other amino acids, proteins, when broken down, our amino acids, can compete with the limited absorption in the small intestines and therefore limit absorption of levodopa. Now, that is for some patients, not for all patients. So there are certainly far more patients nauseated from the medication, at least initially, than those that are sensitive to the protein competition. So almost all my patients at least in the beginning, I tell them, take it with food. One, you'll remember it because you usually don't forget to eat. And then second, it's less nauseating for the patient. And once they're used to it already, and later on, many years later, if they develop wearing off, then I tell them not to take it with food, so it's to maximize the absorption of levodopa. Other things that might interact with levodopa, iron in some patients can interact and limit the medication. So if you're taking iron pills for restless legs or anemia or whatever, you want to separate that from the levodopa just to be on the safe side. The most interaction that we would see, especially in the hospital, are these antipsychotic medications. When patients are admitted, say for a hip fracture or for whatever other condition, and they're in the hospital and they become agitated like any normal patient in the hospital, and they're given these medications to calm them down. A lot of these medications that hospitals normally use to calm patients down or for episodes of agitation or hallucinations while in the hospital worsen Parkinson's and interact with the medication. So you just have to be careful with those.
That's wonderful. Dr. Fernandez, thank you. We're way over the time for you as well as for a very attentive audience. If they were wired into this and you could hear their reactions, I'm sure the applause would stretch from coast to coast and across the ocean. So thank you for this terrific talk. My own feeling just listening to you, and I've had this before, but it was particularly true today, is you really understand when a person who's talking to us is talking from the basis of thousands and thousands of experiences rather than just the book learning or some other example of somebody who's just taking it off the peg. Dr. Fernandez obviously knows whereof he speaks. He's seen people. He's worked with people in all of these situations. It really shows through. We're terribly grateful. I have 5 quick public service announcements. Since we're running late, I'll make them very quick this time. One, please, for our sake and for your sake in the longer run, please answer our online survey. We do take that very, very seriously. It's on your screen right now. It should be. And, of course, it is the most important factor in guiding us to the selection of topics for the next series, which will be 2014-2015, beginning in the fall of this year. So please answer those questions. We take them very, very seriously. Number 2, I want to again thank our corporate sponsors, AbbVie Incorporated and Teva Neuroscience. Both these fine companies have made this series possible, and we're very grateful to them for their hands-off generosity. Very, very much appreciated. Third, an archive. Most of you have been on these calls before, so you're familiar with this. We have an archive of the event that will be made available starting next week, Tuesday, April 15, Tax Day in the United States. And all you need to do is to check in with www.pdf.org, and you will find the archive there beginning 1 week from now. We'll actually be sending you an email with the link when it's available so you can listen to the talk again, or, of course, tell your friends, family, anybody else about it if it particularly struck you. You have dozens more shots at this particular target. So that's 4. And then finally, just a PSA on our next briefing, the last in our series of 2013-14. This will be on Tuesday, June 24, 1 p.m. United States Eastern Daylight Time until 2 o'clock. And the speaker will be a very, very well-known and experienced and brilliant clinician from the Midwestern United States, Dr. Peter LeWitt from the Detroit, Ann Arbor area. And he will be speaking on the topic, Parkinson's disease, gastrointestinal challenges, one of the things that's least talked about and most often experienced by people with Parkinson's. And we're delighted to have this as, I think, the first time we've addressed this particular topic, Eli, in our series next time, Tuesday, June 24th. And also mention as a sub-PSA within a PSA that PDF in its research work just funded through the World Parkinson Congress, which I know many of you on this call attended, a so-called Community Choice Award in which we actually are funding a conference of very, very well-informed and experienced scientists on this very topic, gastrointestinal challenges in Parkinson's and how they can be managed better. So at PDF, we try to have an active two-way conversation between our educational work, represented by this webinar today, and our research work, represented by that kind of support of that kind of conference. So thank you again, Dr. Fernandez, for a fine talk. I apologize again, though it's a kind of a, not really an apology, it's really an announcement that we could not take all these questions. You came with so many that we just were not able to handle them, more than a fraction of them. Please, since many of your questions, and I've seen a lot of them during the course of the talk, are very personal to you, please do call our hotline. We have two very experienced, able young women who have doctors behind them whenever they need, and our hotline, and the number again is 1-800-457-6676. And they will help answer your questions, if not at the time, by consulting with their MD counterparts, and then we'll get back to you. So please do take advantage of this. It's part of what we try to offer as our service, and if it's not possible during the time of the webinar, we do follow up afterwards. So do take advantage of that. Dr. Fernandez, again, thank you for the wonderful talk. Thank you, all of you, for coming and making a record audience today of well over 1,400 people, and we hope you'll come back. Have a great week. Talk to you soon.
Bye.
Bye-bye.